I can see the word.
നമുക്ക് ഡാറ്റാണ്ട് ആറ് എത്തില്ല അതിൽ തലവരല്ലേ ഫോണാണ് എടുക്കുന്നത് പണിട്ടാണ് ഇരുണ്ടോ
Good afternoon. Today, I would like to welcome you all for the second monthly clinical meeting organized by the Sri Lanka Medical Association. And as an Assistant Secretary of the SLMA, I would like to welcome you to this important forum. Today's monthly clinical meeting of the SLMA is done in collaboration with the Sri Lanka College of Haematologists. And today we have a nice, very interesting line of topics. We are going to start with approach to persistent fever with cytopenias, which will be delivered by Dr. Vindhya Leelavatara, consultant clinical hematologist, DGH K-Ball, followed by red flags of HLH when fever signals a life-threatening condition, delivered by Dr. A.M. Pumanthi Karunaratne, consultant clinical hematologist, teaching hospital Polonnaruwa. And another interesting topic, decoding the full blood count, an interactive session on rational investigation pathways, delivered by Dr. Nadishani Adirivikraman, consultant clinical hematologist, Colombo East Base Hospital, Mullaria. So to begin with today's session, I would like to invite the president of the Sri Lanka College of Haematologists, Dr. Surya Kumar from Teaching Hospital, Jaffna, to say a few words to us.
Thank you, Vanti. President, Sri Lanka Medical Association, Honorable Council members and members of Sri Lanka Medical Association, Honorable Council members, members of Sri Lanka College of Haematologists, distinguished speakers, my dear colleagues and junior colleagues, good afternoon to you all. First, I would like to sincerely thank Dr. Manyaka Sumalathilaka and the Sri Lanka Medical Association for collaborating with Sri Lanka College of Haematologists and for providing us with this wonderful platform for academic collaboration and professional exchange. One of the key missions of Sri Lanka College of Haematologists is to strengthen collaboration across specialties to ensure optimal care for every patient we serve. Hematological disorders often present in many different clinical settings, and timely recognition and appropriate referral can make significant difference to patient outcomes. Today's topics have been carefully selected with this objective in mind and are closely aligned with current clinical guidelines and practical challenges encountered in day-to-day clinical practice. These topics are intentionally selected because they reflect common but challenging clinical situations faced by physicians, pediatricians, and other clinicians, and they reinforce the importance of guideline-based practice and multidisciplinary collaboration. I'd like to express my sincere appreciation to our distinguished speakers for sharing their expertise and to organizers who worked hard to make this meeting possible. I also encourage all participants, especially our junior colleagues and trainees, to actively engage in the discussions and make the most of the learning opportunity. With these few words, I wish all of you a very productive and insightful clinical meeting. Thank you.
Thank you, Madam. So I would again welcome all of you on site, and also we have about more than 200 participants online now joining with us for this session, so it's very encouraging. And I would like to kindly remind you that the membership forms for the Sri Lanka Medical Association is available at the registration desk. There are many benefits by getting your membership, so I would like you to I would like to encourage you to get your SLMA life membership as well. And without further ado, I would like to invite Dr. Vindya Neelavatara, consultant clinical hematologist from DGHK Gaul, to start the first topic. And just to add to that, we will take the questions at the end of all the three talks. Thank you.
Good afternoon, everybody. Dr. Vindya Neelavatara, consultant clinical hematologist, DGHK Gaul. First of all, I would like to get this opportunity to thank Sri Lanka Medical Association for giving me this opportunity to do the CME lecture today on behalf of Sri Lanka College of Haematologists. Approach to persistent fever and cytopenia is my topic today, so let's begin. My objectives over the next 30 minutes in my lecture include understanding the pathophysiological basis of fever and cytopenias, identifying the etiologies for the condition, systematic approach to diagnosis and management approach. Just to refresh or just to recall the memory of the physiology of fever, the triggers of fever which initiate the process of fever, they are called pyrogens. There are mainly two types of pyrogens, which are exogenous pyrogens, firstly, which are the substances produced from the external substances like bacteria, which produce endotoxins, for example, gram-negative bacteria. And then endogenous pyrogens, which are the cytokines such as interleukin-1, interleukin-6, and T1 necrosis factor alpha, released by immune cells like macrophages in response to infection and inflammation. The pyrogens trigger the synthesis of prostaglandin, which act on the hypothalamus to reset the thermoregulatory set point. As a result, there is activation of heat production and conservation pathways. Same thing is elaborated here. So let's see the pathophysiological basis of cytopenia in a febrile patient. It can be again categorized under four main categories: suppressive mechanisms, infiltrative causes, consumptive or sequestration, then bone marrow aplasia or bone marrow failure. In infective or inflammatory conditions, there is production of cytokines, interferon alpha, tumor necrosis factor, which would suppress the hemopoiesis, the normal hemopoiesis in the bone marrow. As a result, there will be peripheral cytopenia. Then bone marrow infiltration. What happens here is, you can see the normal bone marrow stroma here, composed of the granulocytic, erythroid and megakaryocytic precursors here. However, if there is bone marrow infiltration, it could be due to blast, atypical lymphocytes, granulomas, or parasites. They will replace this normal bone marrow stroma. Therefore, obviously, the production of normal hemopoietic cells, the white cells, red cells, and platelets will be hindered. In this picture, what I have shown is a lymphoma infiltration. Then consumption of blood cells in the peripheral circulation. What happens here is the production of hemopoietic cells. The hemopoiesis is normally in the bone marrow. However, once they are released into the peripheral circulation, they are being consumed For example, in DIC, within the microvasculature, the platelets are being consumed for the formation of microthrombi. As a result, there is thrombocytopenia in the patient. At the same time, there is intravascular hemolysis going on, giving rise to drop in HB. As a result, there will be bicytopenia. And the other mechanism is hypersplenism. An enlarged spleen can trap and destroy blood cells prematurely. Then aplastic or hypoplastic bone marrow. You can see in the first picture the normal bone marrow stroma. However, in the second picture, you can see the bone marrow is almost empty-like. The reason is the bone marrow is replaced with fat tissue, fat. This is called actually aplastic bone marrow, giving rise to peripheral cytopenias. Then myelodysplastic syndrome. What happens in myelodysplastic syndrome is the cells which are produced within the bone marrow in a patient with myelodysplasia are abnormal in size, shape, and function. So bone marrow itself is trying to destroy these cells, the non-functional abnormal cells within the bone marrow itself. So there will be peripheral cytopenia. In contrast, the bone marrow morphology would appear as crowded, hypercellular. So let's go into a few clinical cases. Case 1, the tropical mimic. This is a 30-year-old male patient with 4-week history of fever, high-grade fever, and massive splenomegaly, which was almost 10 centimeters below the costal margin, and also associated with significant weight loss. Full blood count showed pancytopenia with HB of 6.5, neutrophil 0.7, and keeping the differential diagnosis for massive splenomegaly, which include, wonder whether you can recall, the 5 M's, myelofibrosis, malaria, and myeloid leukemia, which is chronic type, then metabolic diseases such as Gaucher's, and malaria. So in addition, Kalasa is also coming as a differential diagnosis for splenomegaly. So keeping those differential diagnoses as well in our mind, we went ahead with the investigation. So the blood picture just showed a neutrophil left shift. There was no leukoerythroblastic blood picture to suggest myelofibrosis. No malarial parasites were detected. Blood cultures was negative, malaria antigen was negative, so we went ahead with the bone marrow biopsy. So what we found in bone marrow biopsy aspirate was those A mastigotes within the macrophages. You can see the macrophage here, and these are called Leishmania Donomani bodies. Actually, it is called double dot appearance. For this appearance, the nucleus and the kinetoplast of this A mastigote is the reason for this appearance in the macrophages. So the diagnosis here is leishmaniasis or Kalasa, giving rise to fever, pancytopenia, and massive splenomegaly. Second case, the hematological emergency. This patient is a 38-year-old female patient presenting with fever for 2 weeks and coming also with epistaxis and ecchymosis. Initially, the full blood count showed thrombocytopenia, which later progressed to pancytopenia. Then in the blood picture, there were fragmented red cells, nucleated red cells with some abnormal promyelocytes with bilobed nuclei. Wonder whether you can appreciate the presence of bilobed nuclei in the promyelocytes here, which are combined with an isthmus also. And in the second picture, you can see that cytoplasm is much granulated there. So the diagnosis here was acute promyelocytic leukemia, complicated by DIC. I'm not going to elaborate further about this condition because I'll be discussing about this condition later in my presentation. Case 3, hyperinflammatory storm. This is a 24-year-old female patient presenting with high-grade fever for 10 days and a salmon pink rash and severe joint pain. Here you can see the salmon pink rash over the back and back of the knees. The full blood count shows pancytopenia, and keeping this background of sudden being crash, severe joint pain, we wanted to explore the possibility of hemophagocytic lymphohistiocytosis HLH. So these investigations were arranged. Ferritin was quite significantly high, it was 30,000, LDH was high, and fibrinogen level was low. And USS abdomen showed splenomegaly of 12 centimeter size. And we did a bone marrow biopsy. You can see the macrophage, which is engulfing erythroid and the granulocytic precursors. This is called hemophagocytosis. So the diagnosis here was adult onset Still's disease complicated by macrophage activation syndrome. Again, I'm not going to discuss details about the condition because my colleague, Dr. Piumanthi, will be discussing in detail about this condition in her presentation next. Case 4, the marrow granuloma. This is a 74-year-old male patient with chronic cough, low-grade fever, and significant weight loss. And there was pancytopenia in the full blood count, and ESR was 150. And the Mantoux test was done because of this history of fever, cough, and weight loss, along with high ESR, and the Mantoux test was positive, and the imaging with CT showed miliary nodules or tubercles in bilateral lungs. Because of the pancytopenia, we did a bone marrow biopsy, which showed granulomas with caseation necrosis. You can appreciate the presence of granulomas here with this amorphous pinkish material in the middle and the epithelioid cells and a few Langerhans giant cells in the periphery. So the diagnosis here is miliary tuberculosis with bone marrow involvement, giving rise to persistent fever, pancytopenia. Case 5, peripheral consumption. This is a 58-year-old male with a history of chronic osteomyelitis for 6 months duration, having recurrent low-grade fever. He presented with pain and swelling of the right calf, and we did a duplex scan which showed DVT of the calf veins. And during the ward stay, he developed diffuse ecchymosis and bleeding from IV puncture sites. Full blood count shows leukocytosis with drop in HB and platelets. And the coagulation profile was much deranged with prolonged PT, APTT, and the fibrinogen level was low, and D-dimer was significantly high. Blood picture showed fragmented red cells with evidence of hemolysis, and the conclusion had been given as microangiopathic hemolytic anemia. So this is the blood picture. You can appreciate the presence of fragmented red cells and polychromatic cells here. So the diagnosis here is osteomyelitis complicated by disseminated intravascular coagulation. So this is the underlying reason for this patient to have persistent fever and cytopenias. So this is the last case, dual pathology. This is a 68-year-old male patient presents with high-grade fever going up to sometimes up to 40 degrees centigrade, also having productive cough, excessive bruising for 1 week duration. On admission, he was tachycardic and also hypotensive, and there was coarse crackles in the right lower lung field, and also there was extensive ecchymosis on the forearms. There were no lymph node enlargement or hepatosplenomegaly. Full blood count showed pancytopenia, and CRP was 230. The blood picture did not show any abnormality, no abnormal cells apart from pancytopenia, and the sputum and blood cultures were sent, which came back as positive for streptococcus pneumoniae, confirming bacterial pneumonia with secondary bacteremia. Even though the patient was started on antibiotics, according to the antibiotic sensitivity pattern, this pancytopenia did not show any improvement. Therefore, bone marrow biopsy was arranged, you can see that this bone marrow is almost empty-like. So it was a hypocellular bone marrow with a cellularity of less than 15%, where this bone marrow was replaced with fat tissue. There were no malignant infiltration or granulomas noted. So here, the diagnosis is severe aplastic anemia complicated by bacterial pneumonia. Yes, so let's discuss about the differential diagnosis for persistent fever and cytopenias. So these are the main causes for this condition: infections, malignancies, immune and inflammatory conditions, and miscellaneous causes. Let's discuss about infectious causes. In tropical regions like ours, infections are the most common cause for this presentation with fever and cytopenias. It could be parasitic, including visceral leishmaniasis, cholera, as you know, malaria. All the conditions give rise to massive splenomegaly in addition to fever and cytopenias. Then bacterial causes include typhoid fever, tuberculosis, brucellosis, and rickettsial infections. Then the viral causes include EBV, CMV, HIV, and dengue fever. And fungal causes also can give rise to fever and cytopenia. For example, histoplasmosis and candidiasis. However, these type of fungal infections usually are seen in immunocompromised patients. What are the hematological and non-hemopoietic malignancies giving rise to fever, persistent fever, and cytopenias? Malignancies can cause cytopenias either by direct infiltration of the bone marrow, or it could be due to bone marrow suppression through immune dysregulation. Acute leukemias, actually acute myeloid lymphoblastic leukemias, or the subtype of acute AML, which is called APML, acute promyelocytic leukemia. These conditions usually give rise to rapidly progressive or very sudden onset type of bone marrow failure. Then lymphomas, both Hodgkin lymphomas and non-Hodgkin lymphomas. Myeloproliferative disorders include myelofibrosis, then non-hemopoietic malignancies infiltrating the bone marrow. Okay, so what are the immune or the inflammatory syndromes? HLH, hemophagocytic lymphohistiocytosis. It's a life-threatening hyperinflammatory condition, could be primary or secondary. The secondary causes include infection, malignancy, autoimmune conditions. Then macrophage activation syndrome. It is more or less a form of HLH occurring in patients with underlying connective tissue disease. And without having HLH or MAS, patients with autoimmune diseases such as SLE and Still's disease can get cytopenias and persistent fever. What are the other significant causes? Hypersplenism, then nutritional deficiencies, which include B12 and folate deficiencies. In severe form, they can give rise to pancytopenia and low-grade fever. And drug-induced causes, some medications are there which can cause bone marrow suppression, and also sometimes drug-induced hypersensitivity syndromes can also give rise to this clinical picture. Okay, so I'm not going into details about each and every condition I mentioned, but thought of selecting few conditions that I thought would be worthwhile mentioning. Acute promyelocytic leukemia. It is a rare, life-threatening subtype of AML. It is considered as a medical emergency due to severe early onset coagulopathy. Often they present with symptoms of pancytopenia and also with evidence of bleeding manifestations. Severe bleeding diathesis can happen, and 90% of patients experience bleeding. It can range from mild bruising to catastrophic type of bleeding such as intracranial and pulmonary hemorrhages. The suspicion of diagnosis of APMA, this is done with morphology. Blood picture and the bone marrow usually show abnormal promyelocytes with heavy granules and bundles of alveoles. They are called Fagot cells. Whether you can appreciate the presence of bundles of alveoles within the cytoplasm, which are called Fagot cells, in the first picture. And in the second picture, I have shown the bilobed nuclei in the promyelocytes and the characteristic fish mouth appearance in the middle. So the diagnosis will be supplemented with the coagulation profile, which is usually deranged with prolonged PTA, PTT, low fibrinogen level, and elevated D-dimer levels. And there is a characteristic immunophenotyping for APML. And the gold standard confirmation is done with genetic studies, which is the PML RARA fusion gene, could be identified with fish karyotyping or R3PCR, and translocation 1517 is the one which manifests as PML RARA fusion gene. Okay, so how to manage this condition? All trans-retinoic acid should be started immediately upon clinical suspicion, and we should not wait until the genetic confirmation arrives. And it should be followed by induction chemotherapy, and at the same time starting supportive care if there is concomitant DIC is ongoing, with aggressive transfusion to maintain platelet count about 30 to 50, and also replacement of fibrinogen if there is evidence of DIC. So why we are so much worried about APML, or what is the clinical importance of this condition? Firstly, it's a very highly curable condition. It had been a fatal disease once, however, now it is considered as one of the most curable forms of acute myeloid leukemia, with long-term survival reaching up to 80 to 90%. However, despite high cure rates, up to 30% of patients still die within 30 days of diagnosis, primarily due to hemorrhage. And also, the other significance is targeted therapy model is available for these patients. APML serves as a targeted therapy, utilizing agents that would induce cell differentiation rather than direct cytotoxicity, in contrast to conventional chemotherapy. So, a few words about fever in lymphoma. There are key characteristics of lymphoma fever. The temperature could go above 104 Fahrenheit, which could be persistent or recurring. And it could be associated with other B symptoms, which include drenching night sweats, and there can be a losing of body weight more than 10% over 6 months. And there can be patterns of fever in lymphoma, and the Pell-Ebstern type of fever is a classic symptom of Hodgkin lymphoma, where this fever lasts for about a week to 2 persistently, followed by a non-fever period for about week to 2. The cause or the reason behind this type of fever pattern is the release of cytokines by the tumor. So this diagram shows the pattern of fever. You can see within the first week no fever, and over the next week or the 7 days, like the patient is having persistent fever spikes, and over the other week the patient is free of fever likewise. Okay, so what should be the clinical approach when a patient presents with persistent fever and cytopenias? So as hematologists, what should be our approach? We should have a quick look at the blood picture just to catch presence of these findings. whether the patient is having blast in the blood picture, any abdominal promyelocytes or other rods, or evidence of microangiopathic hemolytic anemia to suggest any thrombotic microangiopathies or DICs. So I could not forget this MAS score or the risk score when I'm discussing about the febrile neutropenia patient, so thought of including this slide in this presentation. This MAS score is the one which determines whether this patient needs outpatient or inpatient management when he presents with fever and severe neutropenia. So a score less than 21 is associated with a high risk of serious medical complications. So we need prompt and vigilant attention to the patient on admission itself. So once the patient is resuscitated and the initial the stabilization is done, we should arrange investigations to the patient. So again, I have divided the investigations into 3 stages. Tier 1, these are the baseline lab investigations, and the aim of these investigations are to confirm cytopenia, assessing any organ dysfunction, and to screen for common infections, which include full blood count, blood picture, inflammatory markers like ESR, CRP, and also procalcitonin is very much important to differentiate between the infectious and the inflammatory pathologies. Then reticulocyte count would be helpful to differentiate between to differentiate whether the bone marrow is producing cells or is it a bone marrow failure, which means in peripheral destruction and sequestration there will be a high retic count, and in bone marrow production failure there will be a low retic count. And liver and renal function tests and also infectious screening, including the cultures and the imaging such as X-rays. Then the stage 2 or the tier 2 investigations are the targeted and specialized tests. If the initial screens are negative and we do not have a clue, then we should arrange these investigations which are directed towards specific diagnostic suspicions. They include the nutritional screening, vitamin B12, folic acid levels, then extended infectious workup, including serology and PCR for HIV, hepatitis E, BV, CMV, and TB, then autoimmune markers like ANA, rheumatoid factor, then HLH screening. So the tier 3 investigations are the advanced imaging and invasive procedures. These are reserved for cases where the diagnosis remains unclear despite the extensive blood workup. These include the imaging studies, including abdominal ultrasound of CT scans, then PET scans, bone marrow examination, and tissue biopsies if clinically relevant. Just to summarize the diagnostic algorithm, day 1, blood film, cultures, LDH, ferritin, fibrinogen. Day 2, imaging, maybe with CT, US. Then autoimmune screen, day 3 to 5, bone marrow, and specialized viral PCRs. Then week 2 onwards, PET-CT genetic studies. So how should we manage these patients who present with fever and cytopenias? Obviously, the approach should be tailor-made according to each diagnosis. So it could be management with antibiotics, whether it's empirical, starting empirical antibiotics or starting antibiotics according to the sensitivity pattern of each organism. Then maybe managing the hot patients or the HLH or MAS patients with the specific protocols available. Or it could be managing patients with malignancy-induced cytopenias, could be with cancer-directed specific management or chemotherapy, with along with this supportive treatment. Yeah, so what are the pitfalls that would be encountered in these patients when we are investigating and when we are managing these patients? First one is drug fever. This is often overlooked. Therefore, we need to check for eosinophilia and run timing in relation to the onset of fever and the duration of fever. Then partial HLH. We should not wait for all the criteria, 5 out of 8 criteria to be fulfilled to start treatment for HLH, because if the ferritin is skyrocketing because early treatment would save life. Thirdly, fever, thrombocytopenia in endemic areas. We need to think of dengue and malaria until day 7. If it persists, think of HLH or TB. Coming to the end of my presentation, this is the summary. We should prioritize the urgent rule outs. We should always exclude life-threatening infections and aggressive hematological conditions early in the evaluation. Then we should always use a tiered approach, starting with blood film morphology and nutritional screens before proceeding to advanced tests. And lastly, prompt and timely multidisciplinary coordination between microbiology, hematology, and rheumatology is vital to ensure improved patient outcome. These are my references. Thank you.
Good afternoon. I'm Dr. Pirmanta Karnaratna, consultant clinical hematologist from DGH, Polonnaruwa. First of all, I would like to thank the Sri Lanka College of Haematologists and the Sri Lanka Medical Association for giving me this opportunity today. My topic today is red flags of HLH when fever signals a life-threatening condition. HLH is a rare condition, but it is associated with a significant mortality and a morbidity. However, if we diagnosed it promptly and managed it accordingly, the outcome and the prognosis is really good. I'm going to start my presentation with a case which I came across during my overseas training. This is a 27-year-old previously healthy female presented to the local hospital with a brief period of feeling unwell, which includes fatigue, lethargy, multiple joint and muscle pains, with a rash over face and both upper limbs. And there was fever without a focus of infection and loss of appetite. These symptoms were present for 3 to 4 days when she got admitted to the local hospital. And she worked as a lecturer in a local university. She was unmarried and she was a non-smoker and a non-alcoholic. And she was originally from Pakistan and migrated to UK during childhood. Systemic inquiry did not reveal any significant abnormality. The examination findings revealed that she was very anxious with a very low mood, and she was febrile with high-grade temperature spikes and which were more than 101 degrees Celsius. There was a maculopapular rash over chest and upper limbs. She was conscious and GCS was 15 out of 15 and she was hemodynamically stable. There were bilateral small non-tender cervical lymph nodes. Chest was clear. Abdomen didn't reveal any hepatosplenomegaly. Fundi were normal and there were no any focal neurological signs. Then we proceeded with the examination. The initial investigations on admission, the full blood count was alarming. It revealed severe pancytopenia. HB was 6.4 grams per deciliter. Neutrophil was 0.6 and platelets were 25,000. Renal functions were normal and there were mild elevations in AST and ALT levels, and her fibrinogen level was low at 0.59. CRP was 2 and the ESR was also not very high. The next what we did was a blood film. It revealed pancytopenia and there were no any evidence of hemolysis or any abnormal cells suggestive of a leukemia or a lymphoma. The septic screen was also negative. So in summary, a previously healthy lady presenting with fever, multiple joint and muscle pains, skin rash and severe pancytopenia. So what are the differential diagnoses here? Now, suppose you are sitting in front of this patient and not in this HLH lecture, what would be your differential diagnosis on admission of this patient? Any comments? Yes, autoimmune pathology. Severe pancytopenia fever, anything else? Yes, hematological malignancy. So those are the things we also taught actually. So our differential diagnosis for hematological, whether it's, she's a young lady with pancytopenia, whether it's a hematological malignancy, whether it's some severe, sort of a severe bone marrow failure condition like aplastic anemia, whether it's a severe infection, as Dr. Vindhya described in her previous lecture, there are a lot of infectious causes that can cause severe cytopenias, and whether it's an autoimmune condition or whether it's some form of a toxic. So we also didn't thought of HLH at that point, and it was lower down in our differential diagnosis list. Because of the severe cytopenias and the blood picture didn't reveal any significant abnormality, and all the other investigations were also not suggestive of any obvious cause for this pancytopenia, then we proceeded with the bone marrow biopsy. So the question is like, should we have thought of HLH as a differential diagnosis at that point? Answer would be usually, we don't think at this point. A young lady coming with fever and some somatic symptoms, and it's a very short history. So the bone marrow biopsy, this is the trephine biopsy from that particular patient. Those who are familiar with reporting bone marrows might see there is some increased hemophagocytic activity. Unfortunately, I don't have a bone marrow aspirate biopsy picture of this patient. But this is from the internet. You can see these are macrophages which engulfed bone marrow cells with the precursors. So in her bone marrow also there were a lot of cells like this, which is suggestive of increased hemophagocytic activity. Now with this in the clinical picture, severe pancytopenia with increased bone marrow hemophagocytic activity, and the patient was also deteriorating by that point. That was over like 2-3 days within a very short period. We proceeded with further investigations. The serum ferritin, it was initially 4,000 and within 48 hours, it rapidly increased to 29,000. Initially, we did serum B12 and folate levels and they came back as normal. Triglycerides were elevated. It was 3.7 millimoles per liter. Viral screen was negative. That was positive. And the reticulocyte count and bilirubin levels were normal. Immunoglobulin levels were also normal, and the serum protein electrophoresis did not reveal any abnormal paraproteins. CT chest, abdomen, and pelvis was also normal. Urine pregnancy test was negative. Her ANA was positive, but the ENA and dsDNA were negative. So she was with increased bone marrow phagocytic activity with positive DAT and a positive ANA, with high serum ferritin values and high triglycerides value. And if you could remember, initially there was low fibrinogen as well. We did the complement levels, they were normal, and then we performed 2 other investigations, and these are not familiar to us, I think. The perforin expression and the cytotoxic granule release assay by CD107A expression in response to CD3 and NK cell stimulation. These are tests done to identify primary HLH or the genetic HLH. So if these are normal, it is unlikely to be genetic. In genetic HLH, these investigations become abnormal. So in this patient, we assume that it is unlikely to be primary HLH. So with all these investigations, she fulfilled 5 criteria and the tentative diagnosis of HLH was made. I will come back to this criteria in few minutes. So what is HLH? HLH is an aberrant hyperinflammatory hyperferritinemic immune response that is driven by T cells and associated with the potentially fatal cytokine storm. It is the cytokine storm that cause patient to deteriorate very rapidly and cause all these symptoms. What are the causes? The causes of HLH, it can be primary or it can be secondary. Primary HLH is a Mendelian inherited condition, and we usually, these patients present during the infancy or childhood, but very rarely they can present in adulthood or adolescence as well. Secondary HLH is the common form and associated with infections like EBV, HIV, CMV, but it can happen with any form of infection, but these are the common ones. And also malignancies, and out of malignancies, lymphomas are the commonest. And then the rheumatoid autoimmune conditions like Still's disease, SLE, rheumatoid arthritis, and very rarely other causes like stem cell transplantation, surgery, vaccination can also cause. But out of these, the commonest ones are the infections, malignancies, and the rheumatological conditions. Diagnosis. Now, how to diagnose HLH? Diagnosis is a bit difficult, and to exactly diagnose HLH, it is based on the HLH 2004 diagnostic criteria, but you have to always correlate with the clinical picture and the history of the patient. And I have to tell you that these diagnostic criteria and the management protocols are mainly based on pediatric practice, but for the adult HLH management and diagnosis, the trials and researches are very limited. So in adult practice also, these criteria and management protocols apply. Going back to the HLH 2004 diagnostic criteria, this is what we practice. So if you have a molecular marker consistent with the diagnosis of HLH, then you don't need any other thing. You can straight away diagnose HLH, so which is not possible in our setup. And if you don't have genetic markers, or if the genetic markers are negative, then there are other criteria. There are 8 criteria. Out of these 8 criteria, 5 needs to be fulfilled. These include number 1, fever, number 2, splenomegaly, number 3, cytopenias affecting 2 or more cell lines. For the cytopenias, hemoglobins should be less than 90, platelets should be less than 100, and the neutrophils should be less than 1. And number 4 is hypertriglyceridemia and or hyperfibrinogenemia. You can have one or both. So for the triglyceride, the level should be more than 3 millimoles per liter or 265 milligrams per deciliter. And for the fibrinogen, it should be less than 1.5 grams per liter. Number 5 is hemophagocytosis in bone marrow, spleen, or lymph nodes with no evidence of malignancy. And number 6, low or no NK cell activity. Number 7, ferritin more than 500. And number 8 is soluble CD25 more than 2400. Some of the investigations we can do in our setup, but all these investigations we can't do in our clinical practice. But there are enough things that we can diagnose HLH in our clinical practice as well. But if we are highly suspicious of HLH, now suppose you have increased hemophagocytosis in the bone marrow, but you don't have 5 criteria. In that case, you have to consider it as HLH and start immediate treatment. You don't have to wait until you fulfill all the 5 criteria to treat these patients if it is highly suggestive of HLH. Other diagnostics tools, I mean, like the things that alter in HLH includes hyperbilirubinemia, hepatomegaly, transaminitis, elevated LDH and D-dimer levels. These things help to discriminate HLH from septic shock and autoimmune hemolytic anemias, which can overlap with this condition. And if you have gone through about HLH and if you have read about HLH, you may have come across a score called HS score. This is a HLH probability calculator. If you go into the web, this is available. It's a web-based calculator and it has 9 parameters, which includes underlying immune suppression, the temperature level, the organomegaly, number of cytopenias, ferritin level, fibrinogen, aspartate transaminase level, and the hemophagocytosis in the bone marrow. According to the value or the presence or absence, these parameters are given a score. And then you can calculate the total score depending on the values. And if the total score is less than 90, the probability of being HLH is less than 1%. So that means it's very unlikely. But if the score is more than 250, then the probability of being HLH is very high. So now suppose you don't have the bone marrow, but if you put the HS score without the bone marrow, if it is closer to 200, 250, then it is highly likely to be HLH. So this helps you in day-to-day practice to diagnose HLH in highly suspicious patients. Now the thing is, as I mentioned, this is very rare and there is no single laboratory test that we can diagnose HLH. So we are getting so many admissions to medical casualties and a lot of them are coming with fever. So we can't suspect HLH in all these patients and we can't be doing bone marrow or other investigations in all these patients. So we have to choose to which patient we should do further investigations to exclude HLH. So what are the red flags for possible HLH? One thing is dramatic clinical progression of signs and symptoms despite adequate antimicrobial therapy and or without detectable infectious focus. So if the patient is rapidly deteriorating and if there is no focus of infection or if you have treated the infection with appropriate antibiotics, then you have to suspect HLH. The clinical symptoms that you should be aware includes recurrent fevers, lymphadenopathy, organomegaly, rash, and arthralgias. And these symptoms may progress with an unexpected rapidity and severity in patients with HLH. Other features of HLH include cytopenias, potential bleeding diathesis, wasting, fatigue, edema, dyspnea, diarrhea, icterus. So these patients presents, there is an overall sepsis-like appearance in these patients. Now, why the HLH is missed? Most of the time, we diagnosed it during the latter part of the disease. It usually presents with prolonged fever with sepsis-like picture, so we are more focused on managing the sepsis. And later, when the sepsis is not responding only, we are planning for further investigation. And also it overlaps with sepsis as well as severe dengue. In our setup, dengue infection is very common. And when managing dengue patients, we focus on managing the leaky period and all those things. And usually patients should recover within 1 week. But in a dengue patient, if the patient is not recovering within 1 week, and if the patient is deteriorating with prolonged cytopenias, then we have to think of HLH. And other thing is early laboratory features may be non-specific. For example, ferritin can increase in any infective inflammatory condition, and transaminase levels can go up in any condition. So it's very difficult to diagnose these patients early. And there is no single laboratory parameter which has sensitivity and specificity to allow an unambiguous HLH diagnosis. Therefore, close clinical observation with repeated physical examinations and repeated laboratory investigations are necessary in suspected patients. So when to suspect HLH strongly? If there is fever, cytopenias, and ferritin is more than 3000, then you have to suspect HLH. And the other features are sepsis not responding to treatment, dengue with unusual cytopenias or organ failure, malignancy with disproportionate inflammation, and autoimmune diseases with sudden deterioration. So for this, you have to have a close clinical observation of these patients, otherwise it can get easily missed. Moving to the management, management of HLH is based on the HLH94 treatment protocol. It is highly effective in treating hyperinflammation in adults with HLH. And in HLH, one size does not fit all patients. You have to approach each patient individually. This protocol consists of corticosteroids, cyclosporine A, methotrexate with IT therapy, and etoposide. The management of primary HLH is mainly allogenic bone marrow transplantation. Decision to start HLH-directed treatment depends on clinical judgment and assessment of organ function. Some of the other drugs which are used in HLH includes IVIG and anakinra, which is an interleukin-1 receptor blocker. And in India's presentation also, you heard about this word, the macrophage activation syndrome. So it is again a form of HLH, but we use this word in patients with underlying rheumatic conditions like SLE, rheumatoid arthritis, and still disease. So we label them as macrophage activation syndrome, but both are basically the same, the HLH and the MAS. This is I think this is not very clear, but this is a algorithm of HLH management. This is from the Blood Journal. The article is recommendations for the management of hemophagocytic lymphohistiocytosis. So this shows how we should approach to patients with HLH and how to manage them according to their underlying cause. I'm not going to discuss this in detail. But I would like to tell a few words about the management of the patient I discussed. So she was discussed at HLH MDT, and she was commenced on high dose steroids, that is IV methylprednisolone followed by oral prednisolone. 2 days later, after starting prednisolone, she developed altered behavior with hallucinations and delusions. Now, with these psychotic symptoms and history of skin rash, joint pains, positive DAT and positive ANA, it was thought whether this is a SLE flare-up, but initially she didn't fulfill the criteria to diagnose SLE. But there are some autoimmune features, so we thought this could be SLE. Several MDT discussions were held, and the final decision was taken to manage as secondary HLH due to underlying autoimmune inflammatory disease. So this is the macrophage activation syndrome. She was referred to the hematologic team, and psychosis, there was a query whether it is disease-induced or whether it is steroid-induced. Lumbar puncture and CCT were normal, and because of the psychosis, prednisolone was rapidly tailed off. Instead, she was started on IVIG and anakinra, which is the interleukin-2 receptor blocker. With this treatment, she clinically improved, psychosis settled, blood counts and the other blood investigations were normalized. She was discharged home after 8 weeks, continued on anakinra and low-dose prednisolone for 4 months, and then both the drugs were stopped, and she was closely followed up at both hematology and rheumatology clinics. This is my final slide today. The take-home message of this presentation: HLH should be suspected in unexplained persistent fevers, and always check serum ferritin, which we can do in our setup in atypical severe inflammatory illnesses. Cytopenias and organomegaly are warning signs. Early diagnosis significantly reduces the mortality. Thank you very much.
Good afternoon, everyone. Well, being the last speaker and that unfortunate one who stands between you and lunch, let me try to be concise and finish my talk as quickly as possible. So the task given for me today is to show how informative a full blood count can be. So almost all of us and almost all our patients will get a full blood count done in our day-to-day clinical practice. And do we really pay attention to all the information that is depicted in a full blood count? So we pay attention to the numerical data that is given in the full blood count, and of them also, I guess we would look at the total WBC and the differentials, HB and the platelet, not the rest of it. And there are some graphical illustrations given in the full blood count which can be really informative. So let's have a look at what information that we can gather from a full blood count. Okay, so there are three main areas in a full blood count. One is WBC, platelets, and red cells that we all know about that. In WBC component, you would get total WBC and the differentials. So when I talk about differentials, as hematologists, what we are interested is in the absolute numbers, not on the percentages, because all the definitions and the cutoffs are defined by the total or the absolute numbers. So under red cell component, we get total red cells and hemoglobin, hematocrit, MCV, MCH, MCHC, and red cell distribution width. All are very important parameters. And under platelets, we get the total platelet count, mean platelet volume, and the platelet distribution width. Apart from this numerical data, we get histograms for platelet and red cells and scatter plots for WBC. So in the histogram, the x-axis stands for the volume and the y-axis for frequency. And apart from these histograms, in the full blood count, you would also get some flags, which I will discuss in my next few slides. Okay, so moving on to red blood cell histograms. So, as in any biological parameter, okay, so it's difficult for me to get the pointer. So, as in any biological parameter, if you plot the cell volume against the frequency, you would get a Gaussian distribution. So the mean of the Gaussian distribution would be mean corpuscular volume, MCV. And the stored standard deviation between minus 2SD and plus 2SD is the red cell distribution width. I will explain the importance of RDW or the red cell distribution width later. If this curve or the Gaussian curve is shifted towards the left, that means there's a hypochromic microcytic population. In contrast, if it's shifted to right, that means there's macrocytic population. And there's some, interestingly, you can also get bimodal peaks in
Can someone give me an example where we can get a bimodal peak in the red cell histogram? Anyone? Yeah, so it could be post-transfusion. So in post-transfusion, you would get the first peak. There are two red cell populations which will be illustrated or depicted by two peaks. Okay, so moving on to the first example. So this is a 42-year-old female who has presented with lethargy and increased sleepiness. Since a hematologist is talking to you, this can't be hypothyroidism or any other differentials. This has to be anemia. So let's have a look at her full blood count. So the patient's having hemoglobin of 11.7 according to WHO definition, and is anything less than 12 for a female is considered as anemia. So this patient's having mild anemia, but red cell count is normal. MCV, MCH are a little bit towards lower side. MCHC and RDW are normal. So you can see the red cell histogram is shifted towards left side, and this is simple iron deficiency anemia. In contrast, let's have a look at this case, who is a 32-year-old female presenting with shortness of breath. So sounds like a little bit more severe anemia for her to get shortness of breath. So we are correct. So hemoglobin is 7.9, which by definition is severe anemia. However, her red cell count is normal. MCV and MCH are pretty low. MCHC is low. RDW is high. So RDW usually, this is I told you RDW is red cell distribution width. So RDW can be normal if there is monomorphic red cell population. If you get what we technically call anisopoikilocytosis, that means different shapes and colors, shapes of cells, RDW will be wider. For example, so this is a typical blood film of an iron deficiency anemia, where you can see hypochromic microcytic red cells and some pencil cells, and you can clearly appreciate the fact that the red cell count is low. In contrast, this is a typical blood film of a thalassemia trait, where even though it also has got hypochromic microcytic red cells, the cell population looks monomorphic. Do you appreciate the fact that it's monomorphic? It means the cells are more or less similar in size. So in thalassemia trait, usually RDW is normal, whereas in iron deficiency, that RDW is high. So that's one indicator where you can gather from full blood count to differentiate thal trait from iron deficiency. And MCHC is again is low in iron deficiency. So this one has got low MCV and MCH and high RDW and normal red cell count. So in pure and simple iron deficiency, usually the red cell count is also low. So this has got dual pathologies. There's iron deficiency as well as a thalassemia carrier status. Do you all agree with me? Okay, so because of the finding from carefully looking at the indices of full blood count, you can come to that conclusion. But to confirm, you have to go for other investigations. Okay, there's something called rule of 3 in full blood count. If you multiply red cells by 3, you would get hemoglobin. And if you multiply hemoglobin by 3, you would get hematocrit. This is what is called rule of 3. In iron deficiency anemia, this rule of 3 is preserved. Okay, let's go back to the previous slide. Sorry. Here, this is simple iron deficiency anemia. So here, if you multiply red cell count by 3, you would get hemoglobin. And if you multiply hemoglobin by 3, you would get hematocrit. So here, the rule of 3 is preserved. Whereas here, when there's thalassemia trait in background, the rule of 3 is not preserved because you get normal or high red cell count. So that's another way of sort of differentiating thaltray from iron deficiency anemia by looking at the full blood count itself. Okay. The next case, a 75-year-old man was investigated for pancytopenia. Actually, this is one of the most typical presentation of megaloblastic anemia. This picture I have taken from internet. So here you can appreciate the fact that the red cell histogram is shifted to right, as I said before, and there's macrocytic anemia, MCV is 110 and hemoglobin is 9.2, and RTW is also high because in megaloblastic anemia, you would get ovocytes, teardrop cells. There's a marked endopoikilocytosis giving rise to high RTW. Okay, moving on to next. This is an interesting one where actually I got this from Teaching Hospital Anuradhapura. A 64-year-old patient who's diagnosed with CSCD presented with massive hematemesis and melena, which is a very common clinical scenario in our day-to-day practice. This is his full blood count, which shows marked anemia of 6.3, still normochromic normocity. So if I have enlarged the red cell histogram, here you can clearly see bimodal peak. Okay, so it could be because in CSCD patients, because of poor diet, gastropathy, and continuous leakage from the varices, they can often get iron deficiency anemia. So this could be polychromatic response or retic response on top of having iron deficiency anemia. That's one possible reason for this bimodal histogram peak. Or else, as Madam said, it could be post-transfusion sample. So let's have a look at the blood film, and according to the blood film, it shows a population of hypochromic microcytic red cells along with the population of polychromatic cells. So this could be because of dual population of polychromasia and hypochromic microcytic red cells. Okay, this is another example for bimodal peak. The 31-year-old woman was treated for iron deficiency. You can see at the end of 2 weeks of hematinic treatments, you have a peak in the left side, which is the hypochromic microcytic peak. And there's another peak emerging towards the right side, which is the new cells coming up following the treatment of hematinics. And after 4 weeks, you can see the hypochromic microcytic peak is getting lower, and the rest of the normochromic normocytic peak is getting it's going up. So likewise, you can appreciate the fact that this patient is responding for treatment. So that's another information you can gather by properly reading the full blood count. Okay, so this is a 44-year-old woman who is presenting with fatigue and yellow color discoloration of eyes for 5 days duration. So for a hematologist, this is nothing other than hemolysis. And here you can observe the fact that hemoglobin is pretty low, but MCV is quite high, 118, and the red cell count is also significantly low, it's 1. So this is what the blood film looked like. You can appreciate that there are so many red cell agglutinations. So all these MCV is high because of these agglutinations. And because there's hemoglobin, you get hemoglobin and red cell count is also low because of the hemolysis and because of the clumps. And if you carefully look at the red cell histogram, it never reaches the baseline because the right hand side is comprised of red cell agglutination. Okay, so let's move on to WBC component. So by looking at the WBC component, the information that we need to gather is whether there's a viral infection, bacterial infection, or else whether there's a malignancy. So those are the basic information that we need to get by reading the WBC component. So for WBC, what we get is a scatter plot. For each cell, you will get a dot. So in the x-axis stands the granularity is illustrated, and the y-axis size. So you can see here the most granular cells would be eosinophils. So it will be shifted towards the right,
whereas the lymphocytes stay towards left. And the larger cells goes up towards the y-axis. And along with that, depending on the abnormalities shown in these histograms and scatter plots, you will get abnormal flags, like whether there's a left shift, atypical lymphocyte, blast, like etc., etc. So it will say anything actually, the flag system. Okay, so let's have a look at a few examples of these scatter plots. This is a patient, a 76-year-old patient who has presented with loss of appetite and loss of weight. Sounds a little bit malignant, and he has got absolute lymphocytosis with the hemoglobin, low hemoglobin and thrombocytopenia. So because of the history itself, it's unlikely to be a viral infection. However, and also you can see there is flagging also shown, saying that there are lymphocytosis, whether they are abnormal. There's a query that they could be abnormal. So this is the scatter plot that he has got. Here you can clearly see there's a distinct population in the scatter plot in the lymphoid region. There's hardly, see the cursor here. So hardly any normal lymphocytes, but there's this distinct population itself is abnormal because altogether it's going upwards. It doesn't stay in the particular lymphoid area itself. So this is most likely, and the neutrophils, you can see the blue ones are the neutrophils, they stay there. So only the lymphocytic population is here. You can clearly see that that is abnormal, and that usually this is of a chronic lymphoproliferative disorder. And a 23-year-old boy presented with cervical lymphadenopathy. So he has got a very high count, total WBC of almost 300 with a monocytic predominance. It's 228,000 to the power 3 microliters are monocytes. So here you can see the distinct lymphoid. Is there any way of getting the cursor? So here there's a distinct lymphoid population down the lymphoid area. And along this monocytic up towards up, you can see a distinct abnormal population up there. So that is clearly the entire population is abnormal and a little bit larger, not that granular. So those information can be gathered, and this is more or less most likely from an acute leukemia. Having said that, so nowadays actually we don't really stick to the classification where formal morphology-based classification. So with the modern development, we have identified each and we categorize or call each and every acute myeloid leukemia or acute lymphoblastic lymphoma with the cytogenetic abnormality that it carries. So depending on the abnormality also, you would get different scatter plot. It can be interpreted by a person who has mastered this. So you can appreciate the fact that depending on the mutation that it has, the scatter plot features are also changed. A typical would be the APML1, where you get a flame-shaped scatter plot in APML because of promyelocytes. Okay. A 66-year-old man was incidentally found to have a high WBC when he has checked his full blood count for a routine checkup. So this is again a common clinical scenario, and this man has got a very high WBC count. You can't see it. It's almost 160 into 10 to the power 3. So it's a very high count, and the differentials are not given. When the analysis is confused with the amount and the morphology of the cells, it usually doesn't give you a differential. Then it's our duty before releasing the full blood count to prepare a blood film and to give the differentials along with the possible diagnosis to you. And here the hemoglobin is also low, it's 7.9, and platelets are pretty okay. So this is the scatter plot we got for that patient. Here you can see there's an eosinophil the right hand, the most in the most right hand side corner, you would have got a eosinophil cluster, which is very dense. That means there's eosinophilia, and this neutrophil cluster has gone up, and it has got some immature granulocytes as well. So this is of chronic myeloid leukemia. This is interesting. A 34-year-old man presenting with fever for 2 weeks. So here, there's absolute lymphocytosis of 9, and hemoglobin is 30, platelet is 280. Sounds like a viral infection. Here, the dense peak population stands for lymphocyte, and abutting that, adjacent to that dense lymphoid population, you can see a little bit of pinkish populations sitting over there. So that is, so when we see the blood film, this is what we have seen. These are angry-looking, weird lymphocytes. And the morphological diagnosis is infectious mononucleosis. So in infectious mononucleosis, this is a typical appearance of a scatter plot you would get. These abnormal lymphocytes are sitting next to the normal lymphocyte population. This is another classical example of a 23-year-old girl presented with high fever and body aches. Again, their lymphocyte count is normal, but there is lymphocytic predominance. The absolute neutrophil is 1.9. The lymphocyte absolute is 4. And there's thrombocytopenia, and hemoglobin is normal. So in this scatter plot, you can see there's in pink, you see the lymphoid population, and it goes up above. And if you have get a closer look, you can see there are 2 distinct populations, and this appearance is called as figure of 8 or tilted hourglass appearance, which is typical or classical in dengue fever. Okay. Moving on to the last part of my talk, platelet histogram. In platelet also you would get volume to the x-axis and the frequency to the y-axis. And what you get is either large platelets, as in ITP, and small platelets, as in bone marrow failure syndromes like aplastic anemia or platelet clumps. Those are the common things that we see in our day-to-day practice. So here, in this platelet histogram, it again doesn't reach the baseline. So we talked about a red cell histogram which didn't reach the baseline earlier because of red cell agglutinations. And similarly, can any one of you give guesses for this this graph not reaching the baseline? What could be the reasons? No one to take up that question? No. So it could be again because of platelet clumps. Because when you must have heard there's something called EDTA-induced platelet clumping. So when there's platelet clumps, it can be indicated like this, or even because of giant platelets, or even it could be because of extremely small red cells. Because this platelet histogram and red cell histogram share same features. So if you take the measure, if you consider the mechanism inside what happens inside the machine, it gives the platelet histogram, and later on the red cells also sort of connect to the same histogram. So let me give you an example. This again I have got down from Teaching Hospital Kurunegala. A 45-year-old woman who is getting, was a man who is getting infrequent transfusions, going for his routine full blood count before his next clinic visit. So this is the full blood count. His WBC is 86%, pretty high, with a neutrophil component, and it also says some immature granulocytes are there. Hemoglobin is low and platelets are markedly elevated. It's more than 1,000. So if you carefully look at the platelet histogram, as we discussed in the previous slide, it never reached the baseline. And I will show what the reason is in my next slide. And before moving on to the next slide, let me show you this WBC scatter plot as well. Here, you can see in the lower down, you can see a dense population over here. What can be that? If you can remember the normal scatter plot, any guesses for that even out from hematology trainees over here? What could be that dense population depicted in the WBC histogram? Sorry, scatter plot? No one? Yeah. Okay, let me show you. So this is the actual blood picture. I'm sorry, it's a bit blurred over when it's projected. And here you can see there are small, extremely small red cells. And there are some very small irregularly contracted cells, which is typical, classically we see in hemoglobinopathies. So because of that extremely small red cells and irregularly contracted cells, the machine has counted them as platelets. That is the reason why you have got a very high platelet count. And can you see this is high power. This is a high power picture. So there are two NRBC even in that high power. So there was numerous NRBCs, normoblasts in that blood film. So that those normoblasts are plotted here lower down in this WBC scatter plot. Okay, and so here you can see the red platelet histogram doesn't touch the baseline because it has counted all the red cells and the fragments or the irregularly contracted cells as platelets. Okay, so here again in platelet histograms also you can get bimodal peaks. Again, because of, as we discussed in red cell histograms, it could be because of platelet transfusions or if patient is recovering from chemotherapy, you can get two populations, and platelet aggregations also can really present it as another peak. Okay, so what are the limitations? So I think you have got the knowledge that full blood count can be very informative. For a person who has mastered in that, even that can lead, and even that piece of information can sort of direct it, you towards to a diagnosis. However, in modern day, you really can't satisfy and sit back by doing a full blood count. If there's an abnormality, you have to go for a blood film and subsequently for bone marrow biopsy, flow cytometry, and certainly for cytogenetic and molecular diagnostic methods. So, and also the one limitation of full blood count is you can't really figure out or differentiate blast morphology. You have to go for morphological testing. EDTA-induced pseudo-thrombocytopenia can be a hindrance in full blood count, even though the modern analyzers claim that there are fluorescent tags and there is some impedance method to disintegrate platelet aggregates. The accuracy is yet to be verified. And hemoglobinopathies, you really can't diagnose as such. You have to go for confirmatory tests such as HPLC and electrophoresis. But you can certainly suspect full blood hemoglobinopathies just by looking at the full blood count. And early stages of malignancies can give rise to normal results. So they are the limitations. Having said, so therefore, I would like to highlight that never read numerical indices without histograms and scatter plots. The visual pattern reveals that numbers alone cannot. What numbers alone cannot. Analyzers flags and histograms anomalies are the first line of defense against misdiagnosis of leukemia and severe anemia. Always correlate with symptoms, history, and follow-up tests. Full blood count is a very powerful screen, but not a standalone verdict. That brings to the end of my presentation. Thank you so much, and thank you all for inviting me.
Thank you. I would like to thank all the three speakers for a very informative session. The forum is open for questions. I'm sure you must be having um, many questions. There were a lot of basic information that was elaborated, and it was a very good eye-opening session. Next time I look at full blood count, I'm not going to just brush it over. I'm going to look at it in detail and look at all those scatter plots that we just learned about. Yes, until the things are warming up, yeah, any questions?
Swan, thank you all for joining us, and I'm sorry I'm late. I had another clinic outside of Colombo and just got here, and it was so interesting. I don't think we were taught this 35 years ago in medical school. I thought they were just computer things, for for you all to gather keep some records or something, and we never look at those things clinically. I don't know about this audience. It was very enlightening. I think we should carry this forward to our registrar. Probably the registrars may know, the younger generation might know, but we should do this in a where the more seniors are there. It was very useful what I saw, the little bit. Thank you very much.
Yes, and we also have about more than 200 online courses, so I think so it's very valuable. So I think under the questions are online. Yeah, they are online. Online participants, can we get any questions like from the chat box? Chat box, yeah. Well, until the questions are growing, I would like to ask one question from any of the three speakers. So, well, actually, I have two questions. One is from the first, the case that was illustrated by Dr. Vendya Nilavadura, the leishmaniasis case in the bone marrow aspirate. You demonstrated a very nice picture on leaf donor and bodies. So, when you suspect, when you have a patient with pyrexia and span cytopenia, when you do a bone marrow aspirate, is there a special stain that we have to request to look for leishmaniasis, or these special, or is it routinely done, these special stains? Yeah.
Usually, in the bone marrow aspirate itself, you can see the morphological characteristics of the characteristic features of leishmaniasis infection in the bone marrow aspirate in the morphology itself, without going into specific immunostains or anything, is the double dot appearance with this nucleus and the kinetoblast of the amastigot, which will also that in the trephine biopsy as well. So we don't need actual stains for that. But I want a special stain.
Not like the normal bone marrow aspiration morphology film, we can make some thick films and the same Leishman stain, but different times we can do it. We can get it done. Most of the time, the universities are doing that.
Thank you. Thank you, madam. Any other questions, or I'm going on this?
Actually, I'm not that much familiar with the recent statistics, madam, but as I have heard, within our country, there are a few pockets of leishmaniasis actually, as I heard in Rabukkana, Badulla, and in close to Kekol, Kurunegala, there are a few pockets actually where this visceral leishmaniasis is commonly encountered, but I'm not that much familiar with the statistics, madam.
Well, can I get another question? I'm going to grab all the opportunities to ask questions because it's very interesting. So, one of the there was touching on eosinophilia, and when we have eosinophilia in a full blood count, one of the queries that we have is whether it could be drug induced. So I would like to ask the panel, any of you, to please highlight us on are there any features in the blood picture that you would look for in when you suspect a drug-induced eosinophilia, or is it non-specific, or are there any specific bone marrow features?
Yeah, actually, in the eosinophilia, there are actually the underlying reasons could be broadly two types, which means the reactive eosinophilia and the clonal eosinophilia are the ones that we are talking about. The reactive eosinophilias are the ones which are actually these IgE mediated eosinophilias, where actually the most common causes include the well-known allergies, hypersensitivity, bronchial asthma, parasitic infestations, eczema, likewise. And the clonal eosinophilias include the bone marrow clonal proliferation itself giving rise to eosinophilia. And there is another type of eosinophilia which we are worried about, where there is a malignancy is also coexisting with eosinophilia. It could be acute leukemia, or could be another myeloproliferative neoplasm. In those conditions also, it is also quite a clonal type of eosinophilia. So in the blood picture itself, actually, if it is reactive eosinophilia, we don't see any abnormal cells, any atypical lymphocytes, or any other significant abnormal findings. If it is reactive eosinophilia, the normal, even the maturation sequence will be normal. In contrast, if there is coexisting myeloproliferative neoplasm, acute lymphoblastic leukemia, acute myeloblastic leukemia, there will be the coexisting abnormal cells, blast or atypical cells in the blood picture. Whereas I couldn't talk about the clonal eosinophilias. Clonal eosinophilia means there is a gene type of a mutation, you would say a fusion gene-like thing, which is giving rise to this clonal proliferation of eosinophilia. Even in that condition, we might not see any atypical cells or abnormal cells in the blood picture. So it is therefore, I think apart from the conditions where this eosinophilia is associated with the pregnancy, we cannot differentiate between the we cannot identify the exact cause for the eosinophilia with the blood picture.
Right, thank you very much. Any other questions?
But part, since we see that it's not be must be a reality.
It should be. Yeah. Actually, in conditions, as I told you, the clonal eosinophilia issue is usually due to this, for example, there are conditions like chronic myeloid leukemia and myeloproliferative neoplasms coexisting with eosinophilia. And also there are few mutations which have biological agents which can act on it, such as yes, for allergies actually we cannot use them. You cannot use them because if it is clonal only, that mutation would happen. We could address the tyrosine kinase inhibitors. Usually we use as biologics for the clonal eosinophilias, which will not be useful in reactive eosinophilia because it's IgE mediated. It's another mechanism. Allergic ones.
First of all, I want to thank the speakers for an excellent presentation. I'm a retired pathologist, so I have been, and I practiced abroad for many years. I have one question. I'm not very familiar with HLH. Why is the ferritin, what is the explanation for the high ferritin?
Madam, it's a hyperinflammatory condition. So ferritin is an acute inflammatory marker, what we call acute phase reactant. So in any condition with inflammation, the ferritin goes up. But in HLH, the rise is very significant because there is a cytokine storm.
Right.
So the ferritin levels go up like it's more than 10, usually more than 10,000 in HLH.
It is a rare condition. How often do you see this?
We have come across few cases like in Sri Lanka even because we have dengue here.
Yes.
With
Oh, I
dengue,
see.
HLH is associated, and even with TB, we get some patients with hemophagocytic lymphohistiocytosis. So it's not that very rare. We come across few patients per year.
Thank you very much. It was excellent. Yeah. Yeah, but Canadian, yeah.
And we haven't used the feature, which mainly the duration of eosinophilias.
So, when the eosinophilia is above 1.5 for more than 6 months, of course, we think of more of a clonal. So it's mainly by excluding the reactive causes. So the parasitic infestation, we have to give a worm treatment, cause of DEC if it is necessary, exclude all the allergic conditions. And as you mentioned, the drugs also play a major role, amitriptyline, and most of the antipsychotic drugs, they can cause eosinophilia by themselves. So we have to exclude everything, and if the eosinophilia, especially more than 1.5 persists for more than 6 months, then we have to think of clonal eosinophilia. The main neoplastic condition which causes eosinophilia is myeloid lymphoid neoplasm, where we go for this PIK1, L1, PDGFRA mutation. So it's mainly the number and the duration and the exclusion of the reactive causes for eosinophilia. Yes, worm treatment.
Worm, I think it's allergies. Pollution or I don't know when it pass. Now 6-7% they don't act on it all. Well, what we seems to be 6-8%. Thousand times. And any of this are common cardiovascular diabetes, that's possible. Most of them are statins,
Some glycemic agents can offline, and I can't remember what they are. So in the list, yeah. So some are having. I think some are there, but not. It cannot say every eosinophilia cannot be sort of blamed because of drugs and all. Yeah. So mostly I think it's because of allergies. Exactly, yeah. It's actually difficult in hematologists also because we have to because all these cytological molecular testing is not freely available. So we have to sort of give a, maybe as Madam said, we have to give a course of antivenom treatment and roll out that. Likewise, we go step by step. Patients having an endocrine. But the most we are feared of is endocrine damage because they can get even cardiac manifestations in severe eosinophilia. So, not, yeah, so itself, yeah, because it's quite granular, and if it starts releasing all these granular contents, that can be toxic. Even the endotheliums can get fibrosed. The cardiac chambers can get fibrosed, they say. So they can even stroke, they can get strokes even. So for very severe eosinophilias, we are a little bit worried of. Otherwise, we can buy some time and evaluate.
happens, even if you have benign condition, you can give it the treatment. Then there's the life and broken. It's a best. Yeah, I think this. Any more questions?
All right, in the absence of questions, I would like to wind up today's session. I would like to be very grateful for all the three speakers today. Dr. Consultant Clinical Hematologist from DGHK Call, Dr. Piyomanti Karunaratne, Consultant Clinical Hematologist, Teaching Hospital Polonnaruwa, and Dr. Nandishani Edirivikram, my close friend and batchmate, Consultant Clinical Hematologist from Colombo East Base Hospital, Mulerial. And I would like to thank Dr. Surya Kumar, President of the Sri Lanka College of Hematologists, Consultant Clinical Hematologist from Teaching Hospital, Jaffna as well, and all of you for participating today. Next month. And I would like to thank numerous online participants today as well. Again, I would like to remind you there is the live membership form available at the registration desk. Please pick up the form and take the membership. And next month we will have another fruitful CME session. At the moment is scheduled for 22nd of April, where we will be collaborating with the Sri Lanka College of Emergency. It's the next CME. The next CME is planned for April 22nd in collaboration with the Sri Lanka College of Emergency Physicians. And of course, keep the dates free for the SLMA main congress in July. Thank you.